As with all things arterial, we need to understand where the arteries are distributing to and what they're supplying. This helps with diagnosis, as well as understanding what you're going to see before you even get into the room. So as a refresher, let's look at the homunculus. Now, again, the motor homunculus is going to be on that pre-central gyrus, and that sensory homunculus is going to be on that post-central gyrus, all right? So, again, for both of them, legs and feet are going to be medial, then they're going to go up towards the trunk. Your shoulder, elbow, hands are going to start to be more lateral, and then the most lateral structures are typically your face and other smaller structures out that direction. So keep that in mind as we go through the different arteries. Here we can see both a lateral view of the brain and a medial view of the brain as well. So the middle cerebral artery, that continuation of the internal carotid, the big one right there, has a large expanse here over the lateral aspect of the brain. So if we look back at that homunculus, right, we're going to see this face and hand and arm are going to be heavily impacted. Now, that's not the only things that can be impacted, but typically, motorically and sensory-wise, that's what you're going to see. The blue is the anterior cerebral artery, and that anterior cerebral artery right there is going to be more medial. And so these typically are going to have problems with their legs, their feet. Sensory areas are going to be both leg, feet, and genitals. And then finally, we see this posterior cerebral artery. And what's happening here is most people forget about these little projections forward or anteriorly, rostrally, towards the thalamus and the hypothalamus. All right. So remember the occipital lobe back here, that's mostly vision. And then we're going to have some projections forward into the thalamus as well. So we can see here there's a lot of different divisions. You can definitely look those up. We tend to talk about whether or not the stroke is more towards the origin of the artery or further out. So we can see here we have a lot of distribution for the MCA. It's got some deep branches. It's got different branches that go out in different ways. And what's going to happen is it usually runs this way. And if you were to split open that sylvian fissure, you can see it running up to where it needs to go. The ACA is almost all midline. So it's going to be mostly leg, feet, but there's also some other structures in there that we're going to talk about in a minute that help with behavioral issues and memory and emotion that can be impacted by the ACA. And then just to give you another little perspective of this, the PCA can do part of the temporal lobe as it projects forward, but typically we think of the PCA as the occipital lobe. So let's talk about the big one first, the middle cerebral artery. So this middle cerebral artery is going to originate at that internal carotid. It's going to come up, move through that sylvian fissure, and then divide in different ways here. So it's going to usually do the frontal lobe, temporal lobe, parietal lobes, the internal capsule, which a lot of motor tracts run through the internal capsule, the caudate nucleus, and of course the basal ganglia. So the basal ganglia is all about initiation, stopping movement, starting movement. It's usually implicated in diagnoses like Parkinson's disease and Huntington's disease. And there's a lot of different portions of it, a sphenoidal, insular, opercular, and cortical. All right. And so those are just anatomical ways that we can discuss this with other people. But typically you're going to hear MCA stroke, and then you got to look at the imaging to see where it is. Is it more lateral or more cortical, or is it deep in here? They can have extensive damage. Like I said, this is a huge artery, and usually if you have a stroke, it's going to end up in the MCA. That doesn't mean that it can't end up in other places, but this is the most likely one that it's going to end up in. The anterior cerebral artery, it looks a little weird because when you look at the circle of Willis, we just see it going anteriorly, but not only does it go anteriorly, it's going to loop back around and go towards the medial aspect of the brain. And that's important because remember that middle cerebral artery is just doing lateral. So we have to get something in the middle. And because of this, it's going to do the frontal lobe, the parietal lobe, part of the basal ganglia down here, helps with the corpus callosum, those attachments between the hemispheres, and the internal capsule. All right, so there's several divisions of it. Now, it can help with the cingulate gyrus as well, and so we talked about emotion, impact like that. Sometimes you can get these little tiny strokes or strokes that are right in the middle here, and that can impact that cingulate gyrus. So the posterior cerebral artery, as we talked about before, it's mostly the occipital lobe. All right. Now, if you have somebody with a posterior cerebral artery stroke, a lot of times they're going to have problems with vision. Okay. Now, it doesn't mean that they're blind. Some people have cortical blindness. Some people just have prosopagnosia, which is the inability to see faces. There's a lot of things that it could show up as. And so there's also dorsal and ventral streams, which help us tell what things are, what they're doing. All of those things can be impacted with the PCA. Motor wise, we don't usually get a lot of problems with it. However, dependent on where the stroke is, we could have problems with the midbrain, the thalamus, the hypothalamus. And so you can end up with something called thalamic syndrome. And thalamic syndrome is where they are incredibly sensitive to touch, something called allodynia. So something that shouldn't hurt, feels incredibly painful. They can also have problems with temperature regulation too, and a whole lot of other issues. And then finally, let's talk about the spinal cord. The spinal cord has three branches to it. We have in our deep anterior spinal trough here, our little fissure, is going to be the anterior spinal artery. And that anterior spinal artery is going to originate and descend from those vertebral arteries. Now, it's assisted by other arteries all the way down, such as the artery of Adam-Kivitz. There's another branches that are out there. But what it does is something called a watershed. So it's going to move artery or arterial blood to a vast majority of the spinal cord here. And we see that. If you see the anterior spinal artery right here, we have projections up into the horns, the gray matter here, as well as the white matter. Now, there are lateral spinal arteries that help with this, but the vast majority is going to be the anterior spinal artery. So if we get a stroke in that, which can happen for a variety of reasons, some could be alcoholism from fatty emboli, some could just be clotting disorders. Even with a AAA bypass surgery, sometimes that the artery of Adam-Kivitz gets cut, or some sort of stroke happens, disease process. And so if that were to happen, we would have a bilateral issue with motor and pain and temperature. So we see our lateral corticospinal tract here and our spinothalamic tract. Corticospinal is motor, spinothalamic is pain and temperature. Now, our vibratory and light touch are fine because back here we have two posterior spinal arteries. All right. Now, a lot of this comes from pica, but several can come from different arteries all the way down. Its major tract is the DCML, the dorsal column medial lemniscus, and that's going to do vibration and sensory. So if we have a problem with one of these, we might have a unilateral issue with light touch and vibration. All right. So that's the arterial supply distribution. Let me know if you have any questions in the comments.